Good evening to all. I warmly welcome you to our CellTalk webinar. In today's session, Vijay will deliver the research Neoadjuvant Nivolumab plus chemotherapy in resectable lung cancer. Our speaker Vijay is a senior scientist at Renix who leads bioinformatics, genomics, and next generation sequencing research related activities in the organization. He is currently working on the neoantigen cancer vaccine pipeline projects here. Vijay holds a PhD in Life Sciences from TMC Attract, Homi Bhabha National Institute, Navi Mumbai. His PhD study focused on cancer genomics. Previously, Vijay has worked as assistant professor at graduate and postgraduate degree colleges as well. At Renix, he has gained experience in scientific, operational, and administrative matters. So, without further ado, I would like to invite Vijay to take over the session.
Thank you, Yogita, for the introduction. Welcome everyone for today's CellTalk. Today I have selected an article that is Neoadjuvant Nivolumab plus chemotherapy in resectable lung cancer. The original author is PM Ford et al. And others. So the title is Neoadjuvant Nivolumab plus chemotherapy in resectable lung cancer. The topic that has been selected for today's presentation is lung cancer. This article was presented in the New England Journal of Medicine, which has an impact factor of 176, and it was published in the year 2022. And this research has an impact on resectable non-small cell lung cancer. So introduction. Lung cancer is the third most common cancer in the United States, and over 80% of these total lung cancer cases, these are belonging to a specific type that is called as non-small cell lung cancer. This non-small cell lung cancer, these are slow growing as compared to the small cell lung cancer, and therefore have slightly better outcome as compared to the non-small cell lung cancer. So among the patients diagnosed with non-small cell lung cancer, around 20 to 25% have resectable cancer. That means their cancer can be surgically resected, and this is followed as a treatment option for such kind of tumors. So the patient with resectable NSCLC, that means their tumor can be resected, they can be cured by surgery and followed by chemotherapy. So among the patients who undergo surgery, among them 30 to 55% of the patients, they develop recurrence of cancer and they eventually die of the disease. So this is one of the problematic area which this particular research article is trying to tackle with new treatment therapy regime. So adjuvant chemotherapy for the patients with cancer stage that warrants the adjuvant chemotherapy at higher stages. Neoadjuvant chemotherapy can also be used for the treatment. Neoadjuvant chemotherapy means the chemotherapy started before the surgery, and in some cases this chemotherapy can result into the shrinking of the tumor, and this is shown to be helpful moderately in the survival of the patient. But as I said, as it is helping only moderately, so 5-year recurrence-free survival and overall survival for neoadjuvant chemotherapy is modest, that is only 5 to 6 percentage points. So neoadjuvant chemotherapy, as it is conferring a modest benefit over surgery alone for the resectable non-small cell lung cancer, a new therapeutic opportunity has emerged through some research that is emerged. It is through the use of nivolumab. Nivolumab is a fully human anti-programmed death antibody, PD-1 antibody. So this PD-1, PD-L1, when it is in contact with the immune cells, it restricts the immune cells from further activation against the tumor cells, and therefore the tumor cells survive, and therefore immune detection is restricted. So when this nivolumab is used, it restores the function of the existing anti-tumor T cells, and therefore it enhances the anti-tumor activity through direct or indirect immune system activation. So nivolumab-based regimens have recently been shown to have survival benefit in patients with metastatic non-small cell lung cancer. So with this background, early phase trials have been conducted, and nivolumab-based neoadjuvant regimens have shown promising clinical activity. But phase 3 trials are needed to confirm these findings, and that is what this research article is describing. This is an open label phase 3 trial. Open label means both the patients and physicians know that which patient is undergoing under which category of the treatment. And here the patients with stage 1B to 3A of the resectable non-small cell lung cancers were randomly assigned to receive two types of therapies. In one group, nivolumab plus the platinum-based chemotherapy, and in another group, platinum-based chemotherapy alone were provided to the patients. As I have already discussed, the present challenge is even if we have advances in the adjuvant therapies for resectable NSCLC, identification of effective systemic treatments is needed to improve the patient survival. Objective of the research was to confirm the findings from the early phase trials that showed that the nivolumab-based neoadjuvant regimens have shown promising clinical activity. And second objective was to conduct a phase 3 trial to evaluate the efficacy and safety of neoadjuvant nivolumab plus chemotherapy as compared to chemotherapy alone. Methodology included enrollment criteria that included adults with resectable stage 1B to 3A non-small cell lung cancers. And it also included a performance status score of 0 or 1. And this performance score was on 5-point scale, in which the highest score reflected greater disability. And another inclusion criteria was no previous anti-cancer therapy, and patient had to have a measurable disease according to the response evaluation criteria in the solid tumors. Then pretreatment tumor tissue available to assess the expression of PD-L1 was an essential criteria. Exclusion criteria was patients with known ALK translocations or EGFR mutations were excluded from the study. Coming to trial design and treatment, this trial was called a CheckMate 816 trial. It is a phase 3 trial, open label, and it was an international collaboration. Patients were randomly assigned in a 1:1 ratio to receive either nivolumab 360 milligram plus platinum doublet chemotherapy, or in second group only platinum doublet chemotherapy alone. And these were given in every 3 weeks for 3 cycles before undergoing the definitive surgery. And the surgery was planned to be conducted within 6 weeks after the completion of the neoadjuvant treatment in the both groups. Endpoints for these studies were defined as event-free survival according to the blinded independent central review, or complete pathological response according to blinded independent pathological review, and pathological complete response, which means 0% residual viable tumor cells in the primary tumor and sample lymph nodes. And secondary endpoints included major pathological response, time to death or distant metastasis, and overall survival. The patients that were recruited to the study were 773 were enrolled, of which 505 underwent randomization, and 358 were concurrently assigned to receive the 2 types of therapies. In one group, neoadjuvant nivolumab plus chemotherapy, in another group, chemotherapy alone. So 176 patients were assigned to each group. This is the characteristics, that is balanced characteristics that was maintained in the 2 groups, nivolumab plus chemotherapy and chemotherapy alone. So as you can see, the criteria, the characteristics are well balanced in the 2 groups. The major being age, that is median range was 64 and 65. The distribution for less than 65 years and more than equal to 65 years, it was also found to be balanced. The number of males and females, also the geographic region, although it is not essential. Then the performance status score 0 and 1, those with the earlier stage were more as compared to the stage 1, but in both groups that balance was also maintained. And according to the disease stage, that is 1B or 2 and 3A, these 2 groups, they were also equally balanced. Coming to the next characteristics, histological type of the tumor, that is squamous and non-squamous. These were also balanced between the 2 groups. There's smoking status. The study participants had more current or former smokers as compared to the never smoked one, but among the 2 groups, that balance was also maintained. Then they also checked the PD-L1 expression level, and these were subgroup into less than 1% expression, then less than or equal to greater than or equal to 1% and 1 to 49% and greater than or equal to 50%. And this is the distribution, and that is also balanced. Tumor mutational burden was also assessed. There were some patients in which this was not performed, but among those in which it was performed, they were divided into two groups. Less than 12.3 mutations per megabase and greater than or equal to 12.3 mutations per megabase, and these were also balanced into the randomized groups. And the type of platinum therapy, as it was doublet platinum chemotherapy, there were difference with respect to which drug was used. Cisplatin and carboplatin, these two drugs were used, and these were also balanced within the two groups that were assessed. So coming to the results, among all the patients who underwent the concurrent randomization, 83.2% in the nivolumab plus chemotherapy group and 75.4% in the chemotherapy alone group underwent definitive surgery. And surgery was cancelled for some patients because of some adverse reasons, and those reasons included disease progression in 6.7% to 9.5% in the respective two groups, and adverse events, and other reasons included patient refusal, unresectability, and poor lung function. Now, this survival analysis represents the event-free survival, and as you can see, there is a substantial difference between the two groups, nivolumab plus chemotherapy and chemotherapy alone. At 1 year, the median event-free survival is 76.1 for nivolumab plus chemotherapy as compared to 63.4 for chemotherapy alone, and for 2 years it is 63.8 versus 45.3 months. And also this is at the statistical significance level of 0.005. This is the analysis of event-free survival in the pre-specified patient subgroups. That is to assess that there is no skewedness into the patient population in their subgroup, in their assignment into the different groups. They have also performed this analysis into the patient subgroups also. So as described, age, sex, then geography region, then performance status, disease state, histologic type of the tumor, smoking status, and PD-L1 expression, all the characteristics that have been earlier described, they subgroup those patients into those groups and perform the survival analysis, and they found that this hazard ratio is in favor of nivolumab plus chemotherapy. So as you can see, most of these hazard ratios are coming into the nivolumab plus chemotherapy better option. It is showing that this treatment regime, nivolumab plus chemotherapy, is consistently better across the different subgroups, and within subgroups also there are some differences. As you can see here, that the performance status scores 0, it showed better hazard ratio based as compared to the 1 performance status. One more significant finding was that the disease stage also affected the outcome. That is, it was more prominently effective in the disease 3A as compared to the 1B or 3. In the same way, there were differences found in the PD-L1 expression. Higher expression showed better outcome as compared to the lower expression. Then this graph shows the pathological complete response in the primary analysis population. So there is a clear difference of nivolumab plus chemotherapy showing better outcome as compared to the chemotherapy alone, where 24% of the patients showed pathological complete response. That is the 0% residual viable tumor cells in the primary tumor and the sample lymph nodes, as compared to only 2.2% in the chemotherapy alone group, which is the difference of 21.6% at a statistically significant level. Then this is analysis of the pathological complete response in the pre-specified patient subgroups. Here also, all those criteria for the pre-specified patient subgroups have been analyzed with respect to the how much the outcome was effective in these two groups. That is chemotherapy alone better and nivolumab plus chemotherapy better. As you can see, nivolumab plus chemotherapy has shown better percentage point improvement as compared to the chemotherapy alone group for all the criteria that have been discussed. Coming to overall survival, here also we can see that nivolumab plus chemotherapy showed better survival as compared to the chemotherapy alone. Though initially there is an overlap, both showing median overall survival at 90 percentage, but later it is nivolumab plus chemotherapy showing better survival at 82.7% as compared to the 70.6 months for chemotherapy alone. And it is also found to be statistically significant at 0.08 level. There were some adverse events that were encountered in the study. The adverse events, these are described in this table. So adverse event of any type on any grade was found to be in 92.6% of the patients. And if we subgroup it grade wise, that is grade 3 or 4 and grade 3 or 4, the difference is 40% to the 43%. So the adverse events are also well balanced in the different populations, different groups that have been studied. Coming to conclusion, in this clinical trial, neoadjuvant nivolumab plus chemotherapy, it was found to result in a significantly longer event-free survival, and higher percentage of patients with pathological complete response were found than chemotherapy alone group. Median event-free survival was 31.6 months for nivolumab plus chemotherapy group and 20.8 months for chemotherapy alone group. The percentage of patients with pathological complete response was 24% for nivolumab plus chemotherapy group and 2.2% with chemotherapy alone group. The addition of nivolumab to neoadjuvant chemotherapy did not increase the incidence of adverse events or impede the feasibility of the surgery. Coming to the impact of the research, as these results show better outcome with the use of nivolumab, this is providing a effective treatment option for the patients with resectable NSCLC. Thank you for your attention. You can reach for further queries at this email address. Any questions I would like to answer?
Thank you so much, Vijay, for this detailed talk. Nupur asked, were all the patients treated with similar chemotherapy drugs? Does the result depends on the type of chemotherapy drug used?
So, as I already discussed, two chemotherapy drugs, platinum-based chemotherapy drugs were used, cisplatin and carboplatin. And the patients with cisplatin were more as compared to carboplatin, but their outcome also showed balance. Their inclusion was balanced in the two groups. So these were the two groups that were used. I hope that answers the question.
Nupur further asked, was there a particular reason for not using masking in this study? Why were the rates of the definitive surgery different between the two groups?
As I mentioned, the rates of definitive surgery, it depends upon a variety of different criteria. So, due to the presence of adverse events or occurrence of any unintended outcome, these patients may not go for the surgery, and therefore this different might arise.
Hope it clarifies your doubt, Nupur. Are there any questions from the audience? I don't see. Okay, yeah. We can wait for 2 to 3 minutes.
Okay.
Numer, are you asking something? Okay, yeah. Last question was from the Numer, not from the Nupur. Yeah, sorry for the inconvenience. Yeah. Again, I want to thank you, Vijay, for this educational talk. I'm sure all of us can have a takeaways from this. Vijay, may I request you to go to your final slide? Thank you. Before closing today's webinar, I would like to inform everyone that our next presentation will be held on 12th July 2023, and Jay will be presenting research titled Lung Cancer Prediction Using Robust Machine Learning and Image Enhancement Methods on Extracted Gray Level Co-occurrence Matrix Features. I would like to thank you all for your time and kind attention today. Hope to see you all at our next presentations. Thank you so much.